Three, two, one, and we are live now. So, good evening, one and all. This is Gopikrishna from Chennai, and here we are looking forward for this webinar on dentistry and life after COVID. I'm just waiting for all the systems to be a go before I proceed with my talk. So, I'll just appreciate everybody be patient for a few minutes, and then we take it from there. So once the Dentsply team says it's okay, then I think we can all go ahead with that. So so life in quarantine is quite crazy for all. I guess it's been about 2 weeks, and here we are. Okay, I think the stream is working. Am I right, Vijita? Now. Yes, I think it's there. So if it's fine, I think it's working on my end here. We are able to hear live. Yep. Okay, here we go. Good evening, COVIDians. This is what I'm going to call all of you because here we are staying inside our homes during this enforced quarantine. So the title of my presentation today is Rebooting Dentistry and Life After COVID. This is an insight from me, Gopikrishna. And where does this title and what this whole presentation come from? Those of you who know me, I've been a passionate endodontist, and this is probably my first non-endo talk I'm going to give. I've been known for my various books and journals which I have written. I run a root canal foundation, which you're aware, we train dentists all over the world. I'm a passionate teacher in that sense. But above all this, what I do, where do I spend maximum amount of my time is here. I am inside my clinical room where I work on my patients. And this is what I love doing the most. And I do only endo work, and all these 18 odd years, all my life so far professionally, I've been a focused clinician, researcher, and an academician. And one of my favorite slides, because my primary work has been on disinfection, and one of my primary slides, which I used to be very happy sharing to my students and friends, is this slide which says that in the battle between man and microbes, I used to quote this during my irrigation lectures, and I'll always say in the battle between man and microbes, the microbes will always prevail. They will always win. This used to be my tagline to tell people how difficult it is to disinfect the root canal system. And here we are. And what's happened is that life has been good all these years. We were leading a very pleasant life, all of us very focused on our work and going around. And suddenly here we are. 2020 arrives with a bang. And sometimes life gives you a Corona twist with an extra lemon twist. But this time, I'm not referring to my favorite beer here, but we are talking about what's happening all over the world. We are facing probably one of the greatest challenges what we have faced in the last so many years. And what has happened is this Corona pandemic, which started off as a localized and we event in China, and we just felt that it would just go away like any other disease which happens in a particular geographical location. And as of today, what you see is here we are nearing close to 100,000 deaths, more than 1.5 million people infected around the world. And the most common word talked around nowadays is COVID. And when we see this, the definition of COVID is basically, I'm not going to go into it, but WHO clearly says it's obviously a viral infection which is transmitted by contact with infectious material. This is important because many people are worried whether it's an airborne infection. There is a difference between an airborne infection and what comes because of contact with respiratory droplets, which is what COVID basically is. But my definition of COVID is totally different. According to me, this pandemic is probably the biggest disruptor of social, physical, and economic health in the past 100 years. is in my opinion, this is my definition of COVID, that nothing has ever happened like this ever before. And life till 2019 had been very fine, very nice, and easy go for everyone. Like this nice swan swimming around the lake. So life till 2019 was very simple and nice. This is my definition of COVID. But now, what has happened is we have what we call as a black swan event. And what is a black swan event? Now, it's very interesting about this concept, because till humans knew anything, we knew that the swan is only white in color. And so if you tell it's a black swan, it normally indicates that this is something which does not exist on Earth. Till people ended up going to Australia, they never realized that black swans can also be black in color. This is what they found out once they go to Australia. And that's where this philosophical statement or a phenomenon called black swan event was coined by probably one of the greatest psychologists of this era, called Nassim Nicholas Taleb, who made this statement saying there are certain things in life which are called black swans. And what do you mean by this? What do you mean by a black swan event? It simply means a black swan event is an event which is a very uncommon event. It's very uncommon. That means it's not something which happens day to day. But it's also an absolute outlier, because we have no clue how to react to this kind of events. So if we say it's a black swan event, it simply means something which is not common, and we have no clue how to react to it. And most importantly, for something to be called as a black swan event, it needs to have an extreme impact. What it needs is an extreme impact all around the world. And if you personally ask me, this COVID pandemic is a classic black swan. The last time such a pandemic took place was more than 100 years back. In 1918, the Spanish flu shook the world. Millions of people died. And that's the last time we have a similar kind of globally threatening pandemic. Hence, when we are faced with such black swan events, we obviously are clueless how to handle it. And when it comes to dentistry, and that's what we are going to talk today, how do we handle such an event? Because we have no parallel, we have no studies, we have no wisdom here. How do I tell people, how do I tell myself what should I do during, and most importantly, after this lockdown gets over? What do I do? And that's what I'm going to talk to you. And when I asked this question to myself, this happened about 2-3 weeks back. Till the first week of March, I was lecturing, roaming around, and I was a normal person, just like anybody else. When somebody asked me, what do you think about this pandemic? I would simply say, it's just going to pass off. But after 3 weeks of what's happening now, if somebody asks me what is happening, my answer is this. To be very frank, I did not know how to handle myself. I did not know how to handle my dental practice during this lockdown and afterwards. Now, what this made me do is, I normally, my research, all my quests in dentistry has been always focused on endodontics. But what this made me do is, it made me form a team of people. And so I formed a team of passionate researchers, and we tried to find out answers for this. And we tried to find out answers. How do we handle this situation? What should we do? What we should not do? And we did this and the policy statement which we made was made by a team. And one of the team members is Dr. Kritika Datta. She's an expert on biostatistics and epidemiology and cardiology. So she gave her inputs on that. Dr. Ruchika from Maulana Azad, she is on the ground, in the sense that she has got so much of expertise in trying to see what kind of disinfection protocols can work in an actual clinical setup, as they are handling COVID cases in Maulana Azad Medical College. So she became a resource person who could give us on the ground the challenges faced by doctors, what are the challenges for PPE, and how we can go about with that. The other team member was Dr. Kurinji. She's the professor and head at Satyabama. And what she brought in was her passion was on trying to find out what are the newer ways in which we can disinfect our clinical setups, in what ways we can improvise our clinics to make sure that we are disinfection free. One more of my team member is Dr. William McLean. He's from Glasgow Dental School from Scotland. And he brought in an international input of what is happening in various parts of the world. How was the NHS in UK dealing with this? So what we did was five of us got together online and tried to find out what is the best ways in which we can give you solutions. And the position statement which we brought out is what has now come out as a joint position statement from Indian Endodontic Society, the International Federation of Endo Associations, and obviously Indian Dental Association. And this is what I'm going to initially give you of how we handle the situation. Obviously, right now during the lockdown, we are all inside. Most of us, are in various parts of the world, have been asked not to go outside. So if somebody calls us, what do? We do a dental emergency assessment. We do it only over the telephone. And over the telephone, what are you doing is you are trying to classify your patients into three groups. All elective procedures are called scheduled care, and you will simply say that we don't want to treat you now, come back when the going is good. Then you have a group of patients who have got pain. They call you and say, I have pain, and then you want to know that what to do then when they have pain. And then you prescribe them some medications, and I'll come to that. What are the medications you can give when patients are having pain? And then you have a true emergency. Patient is having a true medical emergency, needs to see you, and those are patients you need to attend immediately. So the first protocol is try to avoid meeting patients. And what do you do when you're trying to avoid meeting patients is you give them some medications. And what are the most recommended drugs of choice? Because when you talk about dental pain, let's all come to the point. The number one chief complaint a patient is going to call us during this lockdown is pain. And when they call us, we're going to give them some medication. So by evidence, what is the best we can give? Although by literature, ibuprofen 600 milligram is probably the best pain-killing medication in endodontic field. Very commonly employed in the European and the American situations, but in India, and moreover now, because of WHO new guidelines, which are not very clear about the interaction of Brufen during this pandemic, so we do not want to prescribe Brufen. So what are we going to do is we're going to give first line of drug, I would say in this is ketorolac-tromethamine. Ketorol 6-hourly 10 milligram is a very potent painkiller for acute pain. You can also try acetaminophen 1000 milligram. It's very effective. In Indian scenario, we also give piroxicam 20 milligram, as well as, although we don't have recorded evidence, but aceclofenac has also been known to show, but we don't have clinical trials to recommend. So the go-to medications would be a combination of acetaminophen or ketorolac or piroxicam would be my top three drugs. With ketorolac, I normally when my patients are calling me now, I'm trying to tell them this is the medication which I normally try to give to them. We do not need to give antibiotics unless the patient is having swellings, because now what I do is, because of WhatsApp, I ask the patients to take some photographs or short videos and send it to me. And I look at the WhatsApp images and then try to see whether there is some systemic signs of infection. Unless there are no systemic signs, I would not give antibiotics. Interestingly, there is evidence for acute pain for the use of steroids in the form of dexamethasone. And I know a few oral surgeons who prescribe this as orally or as supraperiosteal injections. I have not been a great fan of giving dexamethasone, but by literature, it can be used as an adjunct if symptomatic irreversible pulpitis is not getting cured. Then I think you can use that as one of your drugs of choice as an adjunct, while preferably keeping NSAIDs and acetaminophen as your primary line of treatment. Now that's about medication. Next is to understand who is a patient who is at risk. So when the COVID came in, we were asked to do a risk assessment chart. And we were asked to ask our patients over the phone 3 primary questions: whether they had a history of exposure, whether they have temperature, and respiratory symptoms, and more importantly, also ask which geographical location they are in, because the COVID earlier stages 2 weeks back was at a different stages, different things. There were different levels of of incidence of the exposure. But if you ask me now, yes, this is important to know. Ask your patient, because to know that this patient is already having symptoms or not. But personally speaking, if you look at the map of India as of now, today's map, this is the amount of number of districts in which we have COVID confirmed cases. Almost 340 plus districts in India have at least a COVID positive case. In this scenario, if you personally ask me, although we tell we are not into community transmission, we are in only stage 2 right now. But if you ask me, my recommendation to anyone would be to consider every patient as an asymptomatic SARS-CoV-2 virus carrier. That's how I will look at the current situation. If you ask me on April 10th, today, a patient who's even asymptomatic, I would consider him to be a carrier, because we really do not know. And we know that this disease has a very long, at least 8 to 10 days to 2 weeks of asymptomatic phase where the patient can still have no symptoms but can be a carrier. And dentistry is probably one of the most susceptible fields to get contracted with this disease. So my recommendation is, although you take the COVID-19 screening of asking, taking temperature and all, but I would simply say, as of now, consider every patient as a carrier. So what does that leave me? If every patient is a potential carrier, what do I do? I have two choices. I can either, when the patient is now reporting to me and he still has acute pain and I have to see them, then I have to do only two things. Do I perform the emergency procedure? The answer is yes, but you need to make sure that you perform without producing any aerosol. That's the key here as of now. Don't do any procedures which can create any aerosol. And that's why we say, if you feel you cannot do that, then you have to refer to an emergency medical facility. This is what the recommendation we published 2 weeks back. This came about 2 weeks back. Now, the American Association of Endodontics, the AAE, it brought out a guideline just a couple of days back. This is an article which is going to come in the Journal of Endodontics, and their chart, if you actually look, is very similar to what we have recommended. You will just divide your patients under elective, urgent, and emergency care. And one key difference is they say that if you are going to do any emergency work, you have to make sure that you do this in a negative pressure room, or what is known as airborne infection isolation room, in which there is some amount of air circulation where you are removing the air from the room so that there is a good airflow so that the aerosols do not stay back here. So this is very important. Why? Because I will discuss at the end of today's presentation what we should be doing when we start our practices later. When we are forced to do aerosol producing procedures, what do we do then later? How do we handle it? Because I think that is the key question to be answered today. What do we do later when we open our practices? So this is important. But as of now, the recommendation is very clear that if you ask me, since we are inside lockdown, what do we do now? If you ask me now, what do we do? Point one, stay home. Don't go out, stay home, like what the governments are telling till the lockdown ends. If somebody calls us, a patient calls us, what do? We will telemedicate them and try to see how long we can postpone that. That's what we will try to do, telemedicate our patients. And we will handle, if we are forced to go to our clinic right now as an emergency, a patient is in severe pain and you're forced to go to your clinic right now to handle the patient, make sure that you do this only on non-aerosol cases with extreme caution, considering every patient as a carrier, as an asymptomatic carrier, and with proper PPE, which is your personal protection equipments, which is what we'll talk next. Now, this is fine till now. But what happens when what do we do after April 15th? The lockdown might get extended till April 30th, might get extended till May 15th. Perfect. The government tells don't go out. You don't go out. But once the lockdown ends, what do we do? What do we do when the lockdown ends and then we start going to our clinic? And that's the question I want to answer today. And that for to understand the question, first answer question is, how long should we stay inside? How long do we think people are going to get infected? I'm going to show you now a graph which I picked up from the John Hopkins tracker site, which is basically showing you a curve. And the orange worm is the Indian curve, and the red worm is the Chinese curve. And what you see in the Chinese curve is it's flattened out. That's why the whole of China is back to business. They are back to opening up everything because the curve has flattened. Whereas if you look at our curve, we are on the ascending. And like any curve which has an ascending curve, only when it starts to go into the descending or when it flattens, we can simply say that the disease is under control. In epidemiology, we are very clear the time which takes for the curve to go up, the time which is taking for the curve to go up, and the time which takes for the curve to go down, we will realize that the time which it takes for the curve to go down is normally longer than the time it takes to go up. What do I mean by this? If somebody has to ask me, this is a favorite question everybody asks me, how long is this going to last? How long should I close my clinic? How long will I be under threat? Nobody has an answer for this. We don't have all the models which you're seeing are all assumptions. So we don't have an answer. But we have one simple fact to look at. If the curve to go up is taking 2 months time, the curve to take down will also take 2 months, if not more. So if you ask me, the first case was reported in India in the first week of March. In the last week of Feb and first week of March was when our cases started. And we are on April 10th, 40 days. The curve is still not hit the peak. So common sense tells me that the curve is not going to come down for at least 45 to 60 days more. No way it's going to come down. That's common sense. So if somebody asks me this question, when to commence dental practice? We are on 10th of April, and if you ask me if government is opening up things on 15th, shall I practice on 16th? My answer to that is nope. I will not go back to my dental practice on 16th. I will still follow the same. I'll be open for telemedication. I'll be open to speak to my patients and probably do non-aerosol procedures for my patients. They are in severe pain. We need to do a surgical procedure. I'm there for that. But no aerosol procedures. How about May? Can we practice in the month of May 2020? To be very frank, I'm a very optimistic person, but more than that, I'm a very realistic person. In May, I don't think we will be ending up into aerosol producing procedures in our practice. It will be highly unsafe. I want you to listen these words carefully. If you personally ask me, when is the time dentists would be most prone to get this disease from others? I think it would be in the month of May. So practicing in month of May would be, I think, from the first, second, third week. All the 3 weeks will be under the bottom of the peak of the curve. So I would not be wanting to do this in May. So mentally, I have told myself that till probably May end, I would extend myself to be in the same mode where I will be available only for emergency cases which are non-aerosol. So pragmatically, this might change with time, but if you ask me, genuine practice on some form can start probably in June, that too with a question mark. In June, how many, that we can only answer that question when we see the cases, what happened in India and rest of the world, how the curve flattens out in the next 15 to 20 days. So that's my take on when to start your practice. So till May end, I would say definitely no aerosol producing procedures is my prediction. Like anybody else, I'm just predicting based on the facts I have at hand. I'm not a soothsayer, but this is my take on this situation right now. This is an important question which everybody messages me, and that's my answer today for you. So then a question comes is, when I go back, what do I do? How do I protect myself? Because you need to understand, we are the number one, along with the medical frontline personnel, we are the most high risk professions to contract the disease from others. So One of the guidelines which is being given is, should we take hydroxychloroquine as a prophylaxis? So there are a lot of debates on this. And since I told this is a black swan event, what do you mean? As I told you, black swan events means we don't know what to do. So you can't expect randomized clinical trials on everything and expect answers for that. That's how medicine normally works. But right now, what we can do is take all available evidence, the wisdom from the past, try to look at peers and find out what the experts say, and then take calculated but very calculated assumptions of how to answer such questions. So if you ask me, if I'm going to go back to clinical practice and see my patients, even if I'm doing non-aerosol producing procedures, but if I start to see more and more patients in the month of May and in the month of June, I am under a serious risk of contracting the disease. So the only current anecdotal evidence, we don't have randomized clinical trials, but both CDC, which is the Center for Disease Control in the US, and the ICMR, which is the Indian Council of Medical Research, current guidelines say that yes, we can give this hydroxychloroquine prophylaxis, for most importantly, to all health workers involved in the care of suspected or confirmed cases of COVID-19. And I personally think we fall into the bracket if we are getting back to routine seeing of our patients next month. So, in my opinion, taking this drug is prudent to me. But the only couple of points for this HCQ is there are these some case reports which come back of people having heart attacks, or whether it's suitable for Indians or others. So for that, the evidence is this. Please do not take hydroxychloroquine prophylaxis now if you're staying on lockdown at home. So I have not taken it right now. I have not taken this medication right now. Whenever you want to take this prophylaxis, you need to take it after consulting a physician. Why? Because there's a very small, negligible percentage of cases in which there could be a cardiac issues. So I spoke to a couple of cardiologists in Chennai, top senior most cardiologists, and I asked them about HCQ. And what we don't understand is HCQ is probably one of the most prescribed drugs for malaria in tropical countries. And most of us have had history of taking some form of chloroquine because of being in India. And Indians are more subjected to this drug than any other group of racial people in the rest of the world. But still, if you want to be sure, meeting a physician and probably taking an ECG or speaking to them and checking your past cardiac history, and then taking their role and taking either the complete dose, which is a 400 milligram BD, one day, followed by a 400 milligram OD once a week for 7 weeks. So it's an 8-week course. You're not going to take these medicines every day. It's not like you're popping in hydroxychloroquine every day. No, you take it today. If you're planning to practice next week, I would probably take it a week before I go to practice. So if you ask me, will I take it? Yes, I would be taking this, but I'll be meeting my physician. I might take his opinion and then take this 400 milligram BD once, and then I'll follow it up once a week for the next 7 weeks. When I go back to clinical practice in the next 2-3 months, I think it's sensible to take it in India, is my take on this. It is not absolute. This recommendation is not an absolute recommendation. It is only based on my way of looking at things. So I feel it is prudent, and it is not mandatory. So each one can take the pros and cons and go ahead. But if somebody asks me, I would say I'm not taking it now, but when I go back to routine work in a month's time, I would be taking this. Then now let's move it. Okay, so once we go back to routine work, I will be taking some HCQ prophylaxis. And then what is the most important PPE which we would require? For the first aspect I will talk is the role and relevance of face masks. How important this is in this condition, for which I'm going to play a short video now, which is a small 10-second, they have tried to do to see what happens when a person coughs in a room. And what you see is, for the cough droplets to settle down, it would probably take 6 minutes for it to settle down to the bottom of the room. It takes 6 minutes. to come down to the bottom of the room. And this is what happens when every time even an asymptomatic carrier coughs. And this comes from Helsinki, this video, and it tells you why this disease is so prevalent. Why does it spread so fast? Because asymptomatic carriers will cough without their knowledge. This droplet stay in the air for 6 minutes, can travel few meters around, and it would fall down and it would cause the disease. So if you personally ask me, and what is seen by various different sources is that people, if they wear masks, not only symptomatic, asymptomatic people, everybody starts wearing masks, is one of the probably the easiest way in which we can prevent this from spreading. There is a study in which they have found that in pandemics, especially these kind of pandemics, if 80% of the population wears a mask, the outbreak can be stopped, the curve can be flattened. And that's why I'm so happy that now we are having movements which are brought in, which are trying to see that it is mask India, completely mask everybody in the country. Is masking would be much more sensible. Is I think is a brilliant social message. More than staying at home, I think what we need to tell people is we need to wear a mask. And if you look at other countries, other models, the good news for India and the Middle East and this part of the world is we are not the first one to get this pandemic. So if you look at the different models applied, if you look at the most powerful ones, most effective ones is probably done by Korea and followed probably little by Singapore, Hong Kong. And now the Delhi government, I'm happy to have is also see that they have also sent out a directive that everyone has to wear a mask. If you come out of your house, you need to wear a mask. It doesn't matter whether you're a doctor or a patient or you're just going out to buy some groceries, you need to wear a mask. I think this is what you and I, as doctors, need to tell everyone around. This is what we need to post it on Facebook tomorrow, that please wear a mask. Everybody wear a mask if you're going out of your house. And the Indian government, if you look at what you see is the Ministry of Health and Family Welfare has brought out this kind of manuals where they are telling the country, please buy masks. If not, you make your own masks. Because in Korea, Singapore, the population is small and the geographical outstretch of the country is small, and they were able to go distribute masks to everybody. But in our country, in a country like with 1.3 billion people, this is more sensible, asking people to at least make their own cloth masks. But one key point for a cloth mask is it's okay for the general public. So you can tell people to make their own cloth mask and you reuse it, they can wash it. But one key point in the slide is they are only effective 70%. So they are okay for asymptomatic people, but we cannot use this in the medical setup. For you and I, we cannot think of obviously homemade masks and all. We need to go for different kind of masks. And the other thing which you need to educate people is the way they remove the mask, especially the common person who walks into you, not to touch the front side of the mask because that's where the contagion is normally is, or in the inner side of the mask. So these kind of posters, if we are able to circulate and tell the people, makes a lot of sense in trying to break the chain, to trying to make sure that this pandemic is stopped before it enters our dental practices. Now comes the crucial question. Okay, that's about the general public. What about us? What should we use when we go back to work? What should we use if we go back to work tomorrow to see an emergency patient? Let's leave the lockdown out. I need to go tomorrow to see an emergency patient. What do I wear? So what we are giving here is a combination of what the CDC, the Ministry of Health from different countries are recommending. You need to have a PPE, a personal protection equipment, which contains of many things: eyewear, mask, gloves, caps, outerwear and all, but the most important is the mask. So you and I as dentists have been used to the AAA surgical mask, but now we are forced to get what is known as particulate respirators. Especially there are two types. We all now know these numbers, N95 and FFP3. FFP3 is not easily available, so let's not talk about that. So let's go think about the most commonly recommended mask is the N95 particulate respirator. The number 95 is basically telling that it is able to filter at least 95% of viruses when it's coming out inside as you inhale. So N95 is the mask which is recommended, but it is not easily available now. it is a little more expensive, and because of the current situation, much more expensive than a traditional mask. But we need to use a N95, period. Without it, we cannot go see any patient. So if you ask me to cut down my message about mask, it is basically for you and I, wearing a N95 will protect us from viruses. So you and I have to wear it. If wearing a surgical mask will not protect us from these viruses, so it just does not help. So you cannot tell me that I'm just examining a patient, so I'm just wearing a surgical mask. No, don't think like that. Even if you're examining an asymptomatic neighbor, you need to have N95 respirator. Otherwise, don't go near anybody's mouth, because you and I will be very high chances of getting infected. The surgical mask or the cloth mask, we are normally now recommending only to reduce the transmission from asymptomatic carriers. So the surgical mask or the cloth mask, you buy and give it to everyone in your practice, in your front office, to your patients and all, but that is not going to help you and I. Now I'm going to play a small video which will explain how this is to be used. This comes from Singapore, and it's a very useful way of how to use the N95. Please watch this and listen to the video.
Before putting on mask, choose the correct size of the mask and ensure there are no defects. Hold the N95 in your palm with the nosepiece at fingertips. Hang head straps freely below hand. Position the N95 under your chin with the nosepiece up. While holding the N95 in place, pull the top strap over your head so it rests high on the back of your head. Pull the bottom strap over your head and position it around your neck, below your ears. If you have long hair, the strap must be positioned beneath your hair. Untwist the straps. Position the N95 low on your nose. Using both hands, mold the nosepiece to the shape of your nose by pushing downward and outward, while moving your fingertips down both sides of the nosepiece. Perform a fit check by placing both hands completely over the mask. Be careful not to disturb the position, and exhale sharply. If air leaks around your nose, adjust the nosepiece as described in Step 5. If air leaks at the mask edges, adjust the straps back along the sides of your head. Perform fit check again if an adjustment is made. Wear the right size mask. Fit check is mandatory for all users of N95 mask and must be performed every time upon wearing. Perform hand hygiene after putting on mask. Pull bottom strap overhead. Maintain the hold on the first strap. Use another hand to pull the top strap overhead. Do not touch front surface of mask. It should be kept in a new clean Ziploc bag for reuse and discarded at end of day unless wet or soiled. Perform hand hygiene after removal of mask and after putting on the reused mask.
This was a brilliant video which comes from Singapore General Hospital, and the only point here is you saw how to use it, how to don it, doff it, but I want you to make sure that you add one point here. Please use a pair of clean, non-sterile gloves when donning respirator, because we have to think of times when we have to reuse these masks. I'm going to come to the point where we need to reuse these masks, when to reuse, how to reuse these masks. So when you're using a reused or already used mask, I don't want you to hold your hand, which is not gloved, and hold the front of the respirator, and again you have a chance of contaminating the respirator. So make sure you wear a glove when you do this procedure, especially in our scenario where we might be forced to reuse our N95s. The other point is to make sure that you do this qualitative fit test. Normally we wear the mask and straight go on to work, but you need to wait for 1 to 3 minutes trying to breathe in, breathe out, move your head around, bend, talk, and then see whether you are comfortable and there is no air leakage. This is probably one of the warnings which all surgeons keep telling me, that if you are using a respirator, it's useless if it is not, does not have a good fit. So make sure that you learn how to use the N95 and how you wear it, don it, doff it, and do the fit test. So if you ask me, the take home message is this: who should wear an N95? Three people in your clinic: the dentist, which is you; the clinical assistant, you the assistant who's going to hold the suction or going to be inside the operatory where you're going to work, has to wear an N95. The surprising, more important point is the cleaning staff also need to use N95, because one of the highest points of contagion comes from people who will handle our biomedical waste. So make sure that three people in your clinic are using N95s. The fit test is important before using N95. Keep it in mind that that's the most important variable which can make the N95 ineffective if you do not do a proper fit test. By the book, reuse strategy for N95 is not recommended for aerosol producing procedures. So if you take ICMR, you take CDC, you take any guideline, they will say if aerosol is produced, you need to use it single use and throw it away. But the whole world is now reeling why we don't have enough N95s. United States, where 3M is located, has having an acute shortage. 3M USA produces 40 million N95s a month, and they do not have enough N95s to supply the United States medical market. So how will you and I get enough number of N95s from other producers? It's not going to be easy. So we are forced, and that's why we need to think about how do we optimize our N95. What I'm going to give you here is what the Center of Disease Control, CDC US, gives you. They tell you there are two ways in which you can extend. They call it extended use and reuse. What do you mean by extended use? You can use the respirator without changing it in between patients for a 6 to 8 hour session. That means once you wear it, you don't remove it, you keep using it. You can treat more patients, but don't touch and remove the respirator, but you go on for a single long extended session. But you need to make a point that when you use it extended use, make sure you wear a surgical mask over the respirator. That means you're wearing now two masks. One is your primary, is your N95, followed by your traditional mask, which is your surgical mask, which you remove and change after every patient. This way, we call this as extended use, and at the end of the day, you can throw it out. This also is probably not very effective in Indian scenario. Why? Because we do not have enough N95. So CDC now says, yes, you can use, or what we call reuse, N95s. These are normally recommended for non-aerosol procedures. I will come to a point, what do we do if we are forced to do aerosol procedure later? But right now, these are all for non-aerosol procedures that if you are reusing, we can do it in a simple way, which even ICMR is now recommending. You can store in a clean, dry, breathable container like a brown paper bag for 4 days. So if you use this N95 and keep it in a paper bag for 4 days, it gets disinfected by the environment. You remember that viruses cannot survive in the environment beyond a stipulated period of time, especially on a N95 mask in a paper bag, not more than 4 days. So what you need is 5 masks. If you buy 5 masks for each person in your practice, you can technically go ahead for 20 working days for non-aerosol producing procedures. So what you're going to do is you're going to do this: buy 4 paper bags, buy 5 masks, and you will use 1 mask a day and keep the remaining 4 in the paper bags. So what technically happens is you will rotate your masks over the next 20 days. So on the 5th day, you take the first mask, and the 6th day, you will take the second mask, 7th day, the third mask, and that's how you rotate. So this way, this is the way you will be able to do this. Now, these N95s, there's a question which I see on the screen saying, Mahendra Jain asked me how to know the right size. Now, that's difficult. You need to use the first time you need to don it off and do the fit test. That's how you find out which is the right size. There is no standard. It's not like your glove size. It's something. So you have small, medium, large. There are 5 sizes of N95. So you need to do a fit test, and that's the only way you will know which is your right size. There's no other way to use this. So you can use these N95 for the next 20 days, once in 5 days each one. I will answer your questions at the end of the session as we go ahead. I do not want to go between this as I keep doing this. There's a question which I see is about autoclaving the N95 mask. The answer is no. We do not know. We do not recommend now autoclaving because of there are concerns of the fibers, the filters getting affected because of the autoclaving process. So as of now, there are a couple of studies which are going on. One is on UV radiation, and the other study which is going on is to see on hydrogen peroxide vapors, HPV sterilization, but we don't have answers. So if you ask me right now in Indian scenario, the best is environmental sterilization using this protocol, what I'm showing. This is what even the CDC is recommending. Now, if you want to extend the use of these respirators, especially in our country where we need to do that, then I say it is mandatory that you use a face shield over your respirator. So you need to be having 3 layers. You'll have your N95, you'll have your normal mask on top of the N95, and on top of that, you will have a face shield. You have various types of face shields. Again, these are considered to be disposable, used for a day and do. And again, I see in India, we face an acute shortage of this. Whenever I'm calling people, I'm not able to get it. Right now in Chennai, I'm not able to get it easily. So what do we do now? I'm going to show you a small video which is done by one of my colleagues, Dr. Kavita. She's the head of the department at GDC Chennai. And she and her team have done a very quick way of doing, a very simple way of doing a customized face shield. If you don't have anything, I think this makes sense to protect our N95s from getting contaminated. So just watch this quick 1-minute video in which they show how to do this. So this is a video which, if you don't have anything, at least something which you can help to protect your N95s. There's another question about, obviously you will use, when I talk about this, you will have, I'll come to the other PPEs also, but first let's finish about the mask. So what is the evidence for increasing the N95 is this. One, as I told you, use a normal surgical mask over your N95 and dispose the surgical mask after every case, the surgical mask alone. And using a face shield is probably a very important way in which we can prevent aerosol splatter clogging the N95. Remember one thing, if any form of aerosol or any kind of splatter comes in contact with the N95, you need to dispose it. That's why whenever we use it on aerosol producing procedures, we just cannot reuse these masks. So in order to make sure we can use it for a longer period of time, it's important that we have this two-layer of protection between the N95 and the patient. And what about the kind of surgical gowns which we may wear? One is, there are two forms. One is obviously what you see on the left is an autoclavable surgical gown, which is this is the traditional one. The one which everybody is trying to sell us is the disposable surgical gown. This is made of polypropylene. This is what most of us use, but it's quite expensive at each case. Right now, they sell it to us at 2,000 rupees a kit. And if you're talking of 2,000 rupees a kit per person for per day of your work, I don't know how many dentists will be able to do this routinely as we go back into routine work. So if you ask me in the Indian scenario, I would say probably I would recommend going back to your autoclavable surgical gown, but make sure it is a full sleeve gown, which you can, for you and your assistant, which you can at the end of the day get it disinfected and get it autoclaved. It's the only way if you want to reduce the cost of this. So if you ask me, this is a very brilliant chart which Dr. Ruchika had created, and which we would be launching it in the website in probably 48 hours time. You will see this in the Indian Endodontic Society and IDA as our official guideline paper of whom all to use, what to use. So let's talk about the first thing. What do you do? What is the kind of PPE you should give a patient who walks into your clinic? So what you see in the top, inside the red rectangle, is the patient walking in. You need to give them two things. Every patient who walks in, give them a head cap and you give them a surgical mask. Every attender, everyone who walks into your clinic, they need to have a head cap and a surgical mask to make sure that they are not spreading any contagion around. What about your receptionist and other staff? What do you do? In that case, you will again say the same. Your receptionist should have a head cap and should have a surgical mask. They don't need any N95. They are not going to come into your operatories. But the most important is you and your chairside assistant. If you look at you and your chairside assistant, there are two risks you have. The risk when you are not doing aerosol procedures and risk when you are doing aerosol procedures. And that's why we have split it into two levels. If you are doing this without any aerosol procedures, then you need to understand, obviously you will wear a head cap, you will have eye protection glasses, which you need to wear as basic eye protection glass you can wear. And on top of which, you should have your respirator along with a surgical mask on top of it, both the respirator and the surgical mask, and the gloves become a single use, obviously. Now, the only time when you need to remember is if you need to dispose the N95 is if you are going to use aerosol producing procedures. As of now, if you're going to get into aerosol producing, then at the end of the day, you need to throw your N95. If you're forced to do an aerosol producing procedure, the N95, I would not recommend it to be reused like how I showed you in the previous slides, putting them into 4 bags. No, those are only for when you are not touching patients with aerosols. Then the question comes, what do I do for my staff who are coming to clean my clinic? For them, give them a head cap, give them an eye protection glass, and they also need a N95. But their N95 need not be disposed every day. You can ask them to use it over 5 days, as I showed you, because they are the ones who are going to handle the biomedical waste. And please give them gloves because they need to be protected as well, and they should not be transmitters. So this is a chart which you can probably later download from the official websites, which we will share. So if you ask me, the take-home message here is this. Surgical mask is a must for all your practice. Everyone in your practice should be wearing, all your patients wear it. You should wear an N95 covered by a surgical mask and a face shield. Obviously, you'll be wearing a goggle on top of which all this, and the same is for your nurse also. I personally would go ahead with autoclavable surgical full sleeve outerwear for you and your nurse who is in the room, so that we can use it for one full single day and use it for the whole day and then autoclave it. Please give a disposable head cap and foot cover for all. There was some story in Italy saying that most of the patients transmitted the disease because of the footwear. Evidence clearly shows that is not the case, but still, having a disposable head cap and foot cover is basic hygiene to make sure we maintain the sterility of the zone in which we are working. So make it mandatory for all who enter your practice. So this is the basic PPE what I would recommend for anyone who's going to do clinical practice. So what do you do when I'm doing? Let's go to procedures. Okay, what are my recommendations for non-aerosol producing procedures? What are these procedures in which I can go to my clinic and I'm not going to produce any aerosol? We gave these recommendations earlier. This is mainly as emergency management for acute pulpitis. And here, I want you to make it sure that this table is for when you are not going to touch your aerator handpiece. And what do? You do first one thing. When you are having patients with emergency pain, please give them NSAID 1 hour prior to the local anesthesia. So over phone, I would normally recommend my patient to have an NSAID. Like I told you, it could be piroxicam, it could be ketorolac, could be your acetaminophen, anything 1 hour before the procedure. When the patient comes to you, you can use local anesthesia with 2% lidocaine. I personally use 4% articaine. Any one of these two you can use. The key point is allow sufficient time. Patients with acute pulpitis need more time. So 15 minutes for anesthesia to take effect. Make the patient wear a mask again and go out and sit in your reception before you call the patient back again. Give 15 minutes for the anesthesia to work. One of the best supplemental anesthetic blocks which we have seen is buccal infiltration with 4% articaine. And that's the reason I like using articaine, because I can use it as my primary block as well as a supplemental buccal infiltration. 4% articaine in mandibular molars has been proved to be very effective. You can also use intraligamentary injections, but it's a painful and you need to have special needles for that, but intraligamentary injections can be given. The other way in which you can actually improve your the LA effectiveness is by buffering your LA solution. Not very common in India because you need to use sodium bicarbonate in a 1:10 ratio and mix it along with your LA solution, but it is done in some parts of the world. It's also proved to be a very effective way in which you can get very good anesthesia in these kind of emergency cases. So this should be your LA protocol when you are going to touch a patient in this period. In this period, when you're seeing this period in the next 2 weeks to 1.5 months, I would strongly recommend, as you should be trying to avoid all aerosol procedures. So how do we handle now? So the only way is by mechanical or chemomechanical caries, removal techniques. So use a dental dam and make sure, because the saliva is not getting contaminated in the whole procedure. So you will use four-handed technique, have an assistant, and try to use sharp spoon excavators. And in some parts of the world, you can use Solve, but not very popular in India. So my take to my students is to use sharp spoon excavators, but most importantly, slow speed micromotor handpiece. The key point is without water spray. I saw a few people recommending you can use on and off with little water, switch on, switch off the water. No, that's a wrong recommendation. The moment you bring in the aerota, you are creating aerosol. That's period. So you are in a high risk period. So you want to take the risk, that's up to you. But if you ask me, will I take the risk? No, I will only use a slow speed micromotor handpiece without any water spray. And after anesthesia is achieved, then only you will go inside until the pulp is exposed. This is what you do. And then you give a dressing and ask the patient to take medications, and then you use, and then you need to remove the pulp as much as possible. So the mandatory operative considerations, if you ask me, is before we start the procedure, ask your patients to rinse their mouth with 1% hydrogen peroxide or 0.2% povidone iodine. That would be the key. This has been proved to be antiviral. Chlorhexidine, which is very popular in India, does not work for viruses. So please do not use that. You recommend this. I think everybody can easily get 0.2% povidone iodine is what I would recommend, personally speaking. You ask the patient to rinse it. Make sure you do all kinds of procedures, whatever you're touching in this patient's mouth under rubber dam. This is to protect yourself, basically, from the patient's saliva. It's so important. And then you avoid aerosols by the technique I've told you and use a lot of hypochlorite. If you personally ask me, all these years I've been trying to teach my students two things: use rubber dam, use hypochlorite. These are the two things I keep telling in my lectures. And I think COVID, it will make you and force you to use a rubber dam and make sure that you're forced to use hypochlorite. Because if you ask me what is the silver lining for dentistry, is that it will make us much more thorough in our disinfection protocols. This pandemic will make you more thorough. So you have to use period rubber dams, and using a lot of hypochlorite, as I'm going to explain later. So if you ask me, take home messages, all procedures under rubber dam, use spoon excavators. You can use Kerizol, or in Indian scenario, use micromotor with burst, but without water. Gain access into the pulp chamber, and what you can do is, if you're not able to completely do a pulpectomy, you'd place a non-arsenic devitalizer and give a close dressing. This is what they did in Wuhan. There's only one article we have which has come from Wuhan, China, where they were talking about a dental hospital which was handling emergencies. And this is what they did. They tried to do exactly what I'm telling you, and they said the only way they were trying to relieve the pain is by putting a non-arsenic devitalizer, which we normally do not recommend in routine practice. In routine endodontic practice, we do not use it anymore. But in these kinds of crises, there's nothing else. Please use these non-arsenic devitalizers. Do not use liquid formocrosol. I'm talking of specific paste form non-arsenic devitalizers and a close dressing. Make sure and then send the patient off with a dressing. Now comes the question, okay, this is what we will do till say April. This is what we will do in the month of May. When can we start doing aerosol procedures? That's the $1 million question. When do we start doing our crown preparations? When do we start doing access opening with aerotars? When do we do routine prosto restorative work, which is what our bread and butter of dentistry is, prosto and basic restorative work. But these works will involve aerosols. So if you ask me, I would strongly recommend, please do not do these procedures till at least the first week of June. We can probably relook at data happening and then decide. But before that, if you are doing aerosols, wearing PPE, wearing gowns, wearing everything and doing aerosol, I've taken prophylaxis, you are still under a huge risk, which at this point of time, seeing how infective this virus is, I would not take that chance. So aerosols, if you're going to do, we need to handle something else. If you look at any operatory, what we see evidence is from the center of the dental chair, 3 meters. That means 3 meters. 3 meters is more than close to 10 feet. 10 feet circumference around your dental chair, aerosol will spread. This is the area of the highest zone of infection. So it's not about only the patient's mouth. This whole area is going to have a lot of aerosols which are created. So this is the area which you and I need to plan and try to disinfect when we work on these patients. That's why it's so important what I'm going to talk next. How do we reduce aerosols, if at all, when we start? Once the curve starts going down and we start using aerosol procedures, what do we do then? Not now. This is for the future. What do we do in the future? And for that, first thing is to keep disinfected your area. This is what we gave in our guidelines, but basically what you need to see is all your equipments, which are handpieces, and all you autoclave and keep them sterilized. Which are sensitive, heat-sensitive things, you will use 2% glutaraldehyde. But the agent, which is the best agent approved by all bodies around the world, is 1% sodium hypochlorite. If you look at all evidence, 1% sodium hypochlorite is probably the most easily available surface disinfectant, which is easily and economical for one and all. So you don't use sweep and broom. You can mop your floors with warm water and detergent, but at the end of it, you need to use a disinfectant, a hospital disinfectant like sodium hypochlorite. And how do we use this? I'm going to show you. These are the guidelines as of March 2020. So if you personally ask me, the number one surface disinfectant in our operatories for day-to-day use from now on should be 1% sodium hypochlorite. Where do I get this? Should I buy from some shop? Where do I get this 1% sodium hypochlorite? This is what I did. I went to Google and I just now Googled to Big Basket. This is where I get some of my groceries. And you get something called Clorox. On Big Basket, which is an online app. You can get it from any good supermarket. Is this a Clorox liquid bleach is 500 ml, and this contains 6% sodium hypochlorite. Make sure you don't buy other company bleaches which are flavored, this jasmine flavored, lemon flavored. No. Don't add any additives. It should be plain bleach. And what we found was, we were experimenting at home, where we found that the Rin Ala which you get is 4% sodium hypochlorite. So all these bleaches for your white clothes, if you just check them, but if you ask me, the purest, most recommended, if you ask me, is most reputed, is this brand called Clorox, 6% hypochlorite. And what you can do that is, if you take 3 liters of normal water, 3 liters of water, and you mix half a liter with this bottle of Clorox, you get 3.5 liters of 1% sodium hypochlorite. This should be your surface disinfectant. So for 90 rupees, you will get 3.5 liters of 1% sodium hypochlorite. Super, super effective to make sure that you keep your clinical floors, all areas which you can wipe mid thing, could be used with 1% hypochlorite. This is what you should be using. This is what I will be using in my practice. Now comes the question, okay, that's for the surfaces. What about the aerosol? If I'm going to use aerosols later in the month of June or later, how do I make sure that the splatter does not contain viruses? I'll put a rubber dam, I'll take prophylaxis, but what do I do? There is only one evidence right now. There are no other articles we have which talks about how I can disinfect the waterline disinfection. How do I do it? The only evidence we have is an article which came in the Journal of JADA, and which says that 0.01% sodium hypochlorite. I want you to please note this point. It is not 1%. It's 0.01% hypochlorite. You mix it in your dental water line, and then you use, then this is considered to be highly disinfecting against the viruses which they checked. So but we do not know the long-term use of this in our water lines. But right now, for the next 4 to 6 months, I'm going to use this. How do I make this? Very simple. You buy your normal hypochlorite irrigants, which is 5%, or you will get it as 3%. These are the two companies which concentrations you get. If you have 5% hypochlorite irrigant in your clinic, you mix 1 ml, just 1 ml in 5 liters of dental water line. So in 5 bottles of dental water line, you can mix only 1 ml. So take 1 ml in a syringe, mix it in about 5 liters of water, and use this water as your dental water line. Make sure you don't make it too concentrated, more than this, because then it will smell, it will corrode your tubings, and it is not required. If you are using 3 ml, 3% sodium hypochlorite, then it is 1 ml of 3% hypochlorite in 3 liters of water line. That's the ratio in which you should mix it. And this is the only evidence we have. We recently had some reports of people recommending povidone iodine as a mouthwash to be added and done. It's a nice hypothesis, but right now I don't have any evidence to say whether it works or not. So I have something which has worked earlier, which is 0.01% hypochlorite. So I'm going to stick to this for disinfecting my dental water line. What about other areas? What are the other newer things with which we can disinfect our practices? One of them is ultraviolet germicidal irradiation, which is called UVGI. These are specific tubes which are available, which you can use in your practices. And what we have found is that UVC, this is what we call, it's a blue UV light of a particular wavelength between 200 and 280, is very effective in killing viruses. This is what they do in many industries for many years. So right now, what we recommend is what you can use as an adjunct. Now, when I say adjunct, that means we do not have evidence to show that this works against the COVID viruses. But we have evidence to show that it is germicidal. So I am going to use few things which I know will 100% work, like 1% hypochlorite on my floor, 0.01% hypochlorite in my water line. But I'll also add few more things in my practice, so that I'm trying to disinfect my practice as much as possible, especially overnight. I saw a lot of questions on fumigation coming up. I'll answer that also. But overall, we nowadays don't recommend fumigation. So what is that? I can do it in the nights, leave it open, or I can use it throughout the night, throughout the day, is this UV GI radiation. It basically is an ultraviolet light, UVC at 254 nanometers of a particular wattage and strength is what you need. So this is available from various companies. Philips has this, so has few medical based companies have it. And what you need is between 30 This is the key recommendation: between 30 and 40 watts. You get at 17 watts some bulbs, so that means 17 into two bulbs, tube bulbs, means 34 watts you would get. Depending on the size of your operatory, you call a person and then you can install this. The typical cost of this, I believe, is 1,500 rupees operatory to 3,000 rupees, less than that. So per bulb tube is what is the cost. I have not yet done this, but I'm going to do this. This is the first thing which I'm going to do in my practice after I open up, is get a UVGI also added to my existing disinfection protocol. One of the evidences is that when you're using this, is to keep the lamp not at the floor level, but well above your eye level. It should be at a particular height, more than 2 meters height. So you keep it at a higher level so that you can it is able to disinfect the whole room. And also because you're not supposed to stare at these lights for a long time at close proximity. But they are very safe. They do not hurt your eyes because we are away from these tubes, and you can also use it overnight, leave it on overnight, so that in your practice it is keeping the area more disinfected than before. This is what evidence is showing as of now. The other thing which is of much use and which will be used much more in dentistry is HEPA filters. These are nothing but the HEPA means high efficiency particulate air filters. These filters are special filters. They are made of both specialized paper as well as glass, which is able to trap very minor diameter up to the level of 0.3 microns. So HEPA filters are of different types. So I want all dentists to note this, that most of us can be fooled because everybody will come to us and say that we are giving you a HEPA filter. What's important to ask is what is the kind of HEPA filter. They are in various numbers. They come from H10, H11, 12, 13, and 14. The highest levels are H14. So if you buy a H14 filter, it's probably the best in the industry. And what you see on the left side, you see a air filter. This is what I personally use in my practice. It's from the company Sharp. It costs about 20 to 23,000 rupees. But this filter is a H14 filter, and it is constantly filtering the air in your room. Hence, it's able to trap zero point 0.1 micron particles. It's is able to trap. So if there is any aerosol with viruses, then this is the best way to make sure you're able to do that. But this is a standalone filter. It doesn't do anything else, but an expensive way of trying, if you're especially wanting to disinfect the atmosphere inside your practice. At later point of time, you might be thinking of either adding a UVC or having a HEPA filter also added to your practice would be my recommendation. H13, which is the next grade, is what is most commonly used by the dental industry. So many of the new products, I'll discuss that at the end of this presentation, many of the new products in which they are talking about this new suction, external suction for removing the aerosol, are using H13 filters. That's the difference between a standalone filter, which will give you H14, and the suction inbuilt HEPA filters, which we'll discuss a little later. What about fumigation? As of evidence, overall, we see that fumigation is not recommended by any of the statutory bodies nowadays, as we do not have any clear evidence against COVID virus. So the only thing which we have is that hydrogen peroxide vapors is effective. So if you are going to talk about fumigation with HPV, which is silver hydrogen peroxide is what they use, then it is okay. But we don't have evidence against COVID. You already have this device and you use it once in a while. I would say, okay, in the night at the end of your practice, you use a HPV, which is hydrogen peroxide fumigation, and go, it's fine. I personally don't use it since I'm going to use the other kind of adjuncts. One of the adjuncts you can use, HEPA is one of the adjuncts, UVC is one of the adjuncts. You can try hydrogen peroxide as one, but not recommended by anybody as of now in this crisis. But if you ask me now a non-dental question, because we talk so much of dentistry, which do you think is the most visible social invention of the last decade? Something which everybody has bought in the last decade, in the last 10 years. If you ask me in the previous decade, it was the mobile phones. But after that, which was the invention which everybody talks about and bought in the last decade? I personally think it's the selfie stick. The last 10 years, everybody, anywhere, everywhere, it became the most socially talked invention. Why am I asking this question? Because if you ask me, which is the dental device which might become the product of the year of 2020, a device which might be bought by most dentists, a device which has a lot of promise, is the device which is hitting the internet in the last few days. We have no evidence for this, first of all. Do I have evidence that this works? I don't know. But from what I have read, what our team is doing, we see that it has a lot of things which make it a sensible thing to have. It is going to act as a powerful suction to remove aerosols close to the place where the aerosols are being produced, which is from the mouth of the patient. So I find that to be a very, very effective way of dealing with aerosols. So after June, when I'm planning to start my practice, and if I'm going to start aerosols, this might be in my wish list. It's an expensive product, but I don't know the cost yet. Some people say it's about 60, 70,000 rupees. I'm not sure. So I've asked, but there are companies, most of them are Chinese, which are making this. And this is what it does. It sucks the aerosol and it does the two more things inside. It has a basic filter, but below that, it has a HEPA filter, what we talked before. But before the HEPA filter, they have a UVC light, so it disinfects the air, and then it goes through a HEPA filter, which is a H13. Most of these companies are using H13, which I told you is not the best of the line, but it is medically accepted as a H13 filter before the air comes out. So yes, we don't have evidence, but looks to be a very, very promising product of the year, I would say. Now, enough of dentistry. I talked to you about now. Let's talk about life. And if you ask me, this is my personal quote. If you ask me to define life, this is my definition. I say that man knows to circumnavigate the earth, yet most of us are clueless to navigate our own lives. This is an absolute truth of life. We can talk about many things, we can talk about dentistry, but navigating our own life is probably the most difficult thing. And by the time you know the answers for everything, you are already dead or dying, and that's the problem of life. So how do we handle this crisis on a different front, not only dentistry? Now, this is a very interesting image which I saw on Facebook a few days back. This is one of my Facebook friends, Dr. Shruti Goyal, and I saw her posting this image, and I really liked this image. I requested her to share this image, and here's the image which she has taken, a beautiful image of a glass. And now the question I'm going to ask is, we normally see a glass which is half full and half empty. It's very easy. Some people have water, some people don't have water, half full, half empty. Now, in this image, can you tell me which half is full and which is empty? You just don't know the answer. And I think that this pandemic has done that to us. It has treated all of us equal. It has just brought us all down to earth. The rich and the poor, the educated and the uneducated, the old and the young. Absolutely, all of us are treated equally. It does not differentiate whether you are from the United States of America or you are in a poor district in some part of Africa. All of us, this pandemic has just brought us down to an equal platform. And from this platform, if you ask me, we have fears. I see that people are stressed up, we all are worried. And this is a beautiful statue of an African couple. And if you look at this statue, The facial expressions of each one is very clear. The four people: father, mother, uh, a daughter, and a son. It's like mine. So I correlated that all four are looking worried. They're looking worried. And what are our fears right now at this point of time during this pandemic? I think one is fear of death. Everybody's worried, will this kill us? Everybody has to die. But if you look at cold statistics, the probability of this happening is only for the people who are most prone for death or mortality. Is obviously, even in India, we are saying the mortality is high only in people above the age of 60. So most of us who are dentists, you and I might not get killed by this disease, but what is it that you might transmit this disease to somebody in your house who is above the age of 65 or 70? I live with a 91-year-old grandmother in my house. So I'm always only worried of not whether I will get COVID, but I'm worried whether I will bring and transmit it to her and end up me being the person who killed her. So my only take to you is be safe. Don't worry about death too much, because we are not going to be prone. The probability is 97% to 99% of people who will get this will come back. You and I will recover and go back to work. So fear of death is there, but it should not be the main fear. The bigger fear for me is fear of uncertainty. This is the thing. If you are told, right now we are all very clear, till April 15th you have to be at home, so clear. But what is uncertain is whether I can go back on 16th, or should I go back on May the 1st or May the 15th. That's uncertainty. I always tell, this is my philosophy: you can only control the things you can control. What is uncontrollable, don't break your head over that. So, as of now, can you control this pandemic? The answer is no. What I can do is I can be sensible. So, I'm going to be sensible. I'm going to look at the curve. I'm going to see that this India, especially, is going to get the peak in the month of May 2020. 2020 is the crucial month for all of us, for the country, for the world, for 1.3 billion Indians. So it's sensible that I don't go out and spread or get it and spread it at home. So I will stay at home. So my mind is clear. Let's talk about dentistry and aerosol practices after the month of May. That's about uncertainty. But the other thing which many of my students who message me is the fear of financial loss. What do we do? How do we handle this? It's tough. Yes, the next few months are going to be tough. So if you ask what is my take on this, I'll be very frank here. The short-term scenario, which is next 6 to 12 months, patients will not walk in. You and I will not get too many aesthetic procedures, elective procedures. That's going to reduce. Patients will ask for more value. When I say value, they will be looking around because their purchasing power is going to reduce. So they will also want to spend less. So that's going to be a challenge. As I told you, there will be a dip in aesthetic, elective, and prosthodontic procedures. That would be a short-term scenarios. So next 12 months, 6 to 12 months, keep your purses tight, be sensible. It's a winter coming. When the winter comes, you just chin up and stay low, allow the wind to blow, and then you come back. Why? Because I was just Googling and researching about recessions. What is a recession? We are all going into a recession where circulation will reduce. So there have been a lot of recessions. The greatest was called 1929 American recession, then 2008 financial crisis. But guess what? In the last 100 years, the top 10 recession-proof professions on earth, that is the profession which does not get hit when recession happens. Do you know which is the number one profession which is not which is immune to recession? The number one profession is medical and allied health sciences. Doctors, nurses, therapists, dentists do not go into recession. You might not make the same money as earlier, but you will not get hit. You will not go homeless. You will not go jobless. You will not be on the streets scrounging for food. No, that will not happen. We might not make the same kind of money like 2019, but we will survive. So I will always say, be thankful for your blessings than looking at what was the best season in your life. So we are in a good space as a profession, is my take on this. In a long term scenario, life and economy always rebounds, always. So there will be a rebound, and we'll be back to the same space as we are, but not before 12 months from now. You would be stronger, better, most importantly, wiser after this experience. You and I always have been searching for time to spend with family. You always want to have time when you can do things which you always wanted to do. And probably life in this form is giving you that chance to do what you want to do. Whether you want to cook, whether you want to learn something, whether you want to spend more time with your family, whether you want to read that book which you always wanted, watch the Netflix which you wanted to watch, or do something which you always wanted to do in your life. So this was an experience of a lifetime. Not that what we wanted, but it sure is an experience which will make us wiser. If you ask me, you will start appreciating sunrises and sunsets more gracefully. Yesterday, we saw a rainbow in Chennai at 4 p.m. I've never seen a rainbow in India before. I've never seen a rainbow unless I'm on a vacation ever. So the first time I see a rainbow in India is now. So, no, it's not so bad. I just was thinking that this is probably a harbinger of better times. So, what do I foresee for dentistry in future? Is very simply short-term loss, but yes, in the long term, you will gain. Long term, we will gain because we will come out of this experience more wiser and stronger. And these are opportunities you learn. The amount of webinars which is going around the world right now is unbelievable. The amount of time you get to listen to others. We are always busy talking. Including me and all speakers, and now we have time to listen to other speakers. So it's a brilliant initiative by many companies, and you can become more wiser in this whole period. One of the questions which is asked to me frequently in my lectures is A, how much I charge for my root canals, and B, one of the questions most guys ask is which car do I use? And you have the image in front of you. The answer is not a Mercedes Benz. Okay, that's not, I don't own a Mercedes Benz. Let me get that clear. But I'm always fascinated by the symbol of a Mercedes Benz. And this is my definition of my circle of life. I read a lot of books. I ask my friends to recommend psychology and other books which helps me in life. And from all my reading, this is my own understanding. A life which is balanced and which is very happy is a bar life like a Mercedes Benz symbol. It's a circle with a star which is dividing the circle into three equal halves, three equal parts. Try to keep, and this is how I like to lead my life, which I feel it might give us meaning in the end. One third of life is profession. I know dentistry is what we all do, but it is not the end of life. It is just one third of our life. It is needed for us to earn money, to lead a life, to help our patients. That's it. You have another important part of your life. Equal one third is your relationships, your family, your friends. This is the time for you to speak to people you have never spoken to, rebuild your relationships, and that's so important. Tell stories to your children and others, and listen to stories from your parents. Relationships should make one third of your life. The other one third of your life, which is you alone, I always say, is one third of your life is a process which you're alone, because it needs you alone to grow. Nobody else can grow with you. It has to be self growth. So if you create time to spend for your profession, your relationships, and self growth, at the end of it, no matter how this pandemic, how long it goes, I think we all will lead a very nice circle of life. That's my take. When people ask me, what do I do when there is a trouble? I keep my life like this circle. That's how my recommendation to you is. My last couple of slides is this. What do you see in this image? You see a kid smiling, but the kid is alone. Am I right? Is there anybody else in this picture? No, the kid is alone. But if you ask me, the answer is wrong. There are a lot of things which are together in this image. The candles all are together. There's so many people, when they are together, they light the world together and make it brighter. So you and I might think we are alone at our homes. We are all alone. We are not, nobody is there. I'm fighting this war alone. I don't think so. Life is much more than that. If you and I together stay positive, have the right attitude, learn the right lessons of life, and become wiser and go ahead, I think we all can come out of this in a much better place and make our earth a much better place, is what I personally take of this. So in the end, if I have to tell you, what will I do when I go back to my practice? What will I do when I go back to my dental practice? This is what we all listening for. This is what I will do. Whenever I go back to my practice, this is what I will do. I will have visual alerts in my reception so that all my patients understand what is etiquette. Keep a seating arrangement with social distancing of 1 to 2 millimeters so that patients, whenever they come to your practice for the next 6 months, I will maintain seating arrangement with some social distancing. Insist on alcohol based hand rub for all. Anyone who walks in, they have to make sure they clean their hands with a alcohol based hand rub. Insist on a face mask for both your patients and attenders. Everyone who walks in should wear a mask and a head cap if possible for everyone. Give a provision for hand wash with soap and water so that they can wash better, and avoid as much as possible AC, because air conditioners are a big way in which we recycle the air atmosphere, and use natural and mechanical ventilators if possible. The other thing is, when I go back to active work, I will take hydroxychloroquine prophylaxis. The dosage is there on the ICMR website. You take 400 milligrams on day one, and you wait for 1 week. That is, you take 2 times 400 milligram BD. And after that, every week for the next 7 weeks, you take one tablet once a week. So you take for 8 weeks, only once a week, you take the course. That's it. You will wear a proper PPE whenever you go to work. That includes autoclavable gowns, goggles, my N95 respirator, a surgical mask on top of the N95, and a face shield on top of that. I will make sure I wear my gloves. I also have footwear coverage. I'll make sure I give this to my assistant who's in my room. I will keep my dental water line disinfected with 0.01% hypochlorite when I use aerosols. I will use a surface disinfectant with 1% sodium hypochlorite for the whole of my practice. This is what would be my protocol. What adjuncts can I use? I can use a HIPAA filter standalone unit, which I already have, but I feel is not enough. I might add a UVC light. These are all adjuncts. We don't have proof, but there's something which can probably make our practices much more disinfected. And extra oral suction and disinfection device is a very interesting thing. I don't own it, but something I might seriously think of buying because of all the advantages what I explained earlier. With that, I will come to an end of my presentation. I would like to thank my team, Ruchika, Kritika, Kurunji, William, all of them. It was wonderful. 5 of us, we worked over the last 1 month trying to find answers. And all these answers come from our team to all of you. We wanted to have answers, and these are my answers for you. My teachers, my family, and my friends, they give me joy. That's what life is about, to need people to spend joy with. So it's an absolute thanks to them. Thanks to Team Densplice Irona, because they are the one who asked me to do this webinar. They called me and said, can you do a webinar on this topic? And I was very surprised. I was thinking I'll do an endo procedure webinar, but this is much more meaningful to me. It gives me a lot of satisfaction in giving this webinar. And thank you, Team Densply, Vijeta and Rohit, for you to bring this all. And absolutely, but last but not the least, it's you. Thank you, all of you. I see thousands of you listening to this webinar, and I hope this gives you some information which is useful and takes you on the right path where we can break this chain and come back to normal life. And those of you who would want to connect to me, these are my details. You can take down my mobile number, in which you can WhatsApp me, my email, and my website, Root Canal Foundation. Later, I would also put it in my website. Also, you will see it in other websites, our